Thank you, dear chairpersons, for your kind introduction. First of all, I would like to thank the SASLT for the kind invitation and my dear friend, Dr. Faisal Abel Khail, for his kind invitation to participate in this elegant meeting. Thanks for the hospitality. My talk today is, or my task is to have a highlight about the updates in obese liver transplant candidates and the challenges evidence-based solution. Of course, we do have a variety of medical treatment, starting from the lifestyle, pharmaceutical, and endoscopic, ending up by bariatric surgeries. The gold standard for the treatment of obesity is bariatric surgeries, with its variant types, depends on the indication. But let us focus in some facts. First of all, the indication of bariatric surgery is for BMI more than 40 or BMI more than 35 plus one comorbidities. They are very rapid and effective for weight loss, but one from every 100 patients indicated for bariatric surgery, they do go for surgery. If we look here for the peak morbidity and mortality for global obesity, we will find here that the bariatric surgeries are indicated from the BMI more than 35, but the peak is away from this. And so we are having a gap for those indications of bariatric surgery with wide gap for unmet needs for PMI for surgeries. We all know the biggest loser. This is American show, which recruits participants to make exercise and diet control, weight loss, and the one who will lose the most weight, he will win by the end of the show. And they did a clinical trial for those participants, and they found those who lost weight, which reached up to 60 kilograms as a mean value, they found after 6 years in those participants, they regain weight with a mean value of minus 20. So should we consider this as a failure that from what they have achieved at the beginning, or they are still successors? There are some facts again. To control the diabetes or reduce the incidence, we need to reduce the total body weight by 5% at least. And for the muscle, cardiovascular, and sleep apnea, we need it below more than 10% of the body weight. And the same thing for the steatohepatitis. We found that the greatest effect for who lost more than 10% of the wood of their weight, they have 90% achieve resolution of their NASH and 45% achieving for fibrosis regression. So in those who are participating in this show, who are still maintaining their weight below than or more than 10% of their baseline, they still are considered as successors. So recently for liver transplantation for NABL during and after the era of hepatitis C, we will find from the year of 2014, after achieving of treatment of hepatitis C, that the indications of liver transplantation for obesity or NASH liver disease are growing up. And this is also because the long-term complication of the immunosuppressive therapies, drug-specific induced or class effect or genetic effect. And they are integrated to insult the diabetes, the hypertension, dyslipidemia, and the NAFL disease, obesity. Of course, the calcineurin inhibitors are incriminated in this for the metabolic syndrome after transplantation. And one of the facts, again, for those part of patients away from the general population, that the post-transplant recipient, they have the risk to develop metabolic syndrome in 50% of them at 6 months after transplantation. And if we try to show that the risk before and after transplantation during 1 to 3 years, that the hypertension increased from 15% before to 60%, four-fold increase, for the diabetes to 30%, which is two-fold increase, hyperlipidemia in 50% within 1 to 3 years, and metabolic syndrome in 50%. So we are again in front of challenges for those patients to have recurrence of the primary disease, which is the MASLD after transplantation, or it could be de novo for those patients. There are, in the AASLD guidelines, for those patients who had diabetes, for example, that the tacrolimus is accused more than the cyclosporin and again the steroids. The hypertension, cyclosporin is more incriminated in that more than the tacrolimus and again with the steroids. And the hyperlipidemia with the mTORs and then the cyclosporins and the tacrolimus with the steroids. So our aim in those patients is to reduce the CNIs as much as we could after transplantation. If there is availability to stop the steroids post-transplantation, this will be a very good option for those patients plus the medical treatment. The International Liver Transplantation Society recommended to integrate the exercise and nutritional workup for those patients, specific medication, bariatric surgery, and again to minimize the CNIs and the steroids as much as possible. This is recently published consensus for the rethinking for the false dichotomy between the pharmacotherapy and the surgical interventions by the American Society of Transplantation and the Liver and Intestinal Community of Practice. And they confirmed that the anti-obesity medications are indicated for BMI more than 30 or more than 27 plus 1 comorbidities. And they divided the medication of pharmacotherapy into incretin therapy or non-incretin therapy. And from this table, we found that the most effective medical treatment for those patients of the semaglutide and the tirzepatide for those patients, they have no drug-to-drug interaction with the immunosuppressive therapy. They have lower rate of weight loss compared to the normal population. We will find here that the semaglutide is having 6 to 8% weight loss within 12 months. But again, with the tirzepatide, they have 7% weight loss in 6 months after transplantation. And they also said they have no drug-to-drug interaction with the immunosuppressive therapy, but they are still not indicated in decompensated cirrhosis, and there is no dose adjustment for liver impairment. Some medications like the orlistat, they have a mean weight loss of 3%, but there is no significant weight loss for transplant population. They highlighted that there is a drug interaction between the orlistat and the cyclosporins, so we have to keep a gap between them. Again, the endoscopic therapies with intragastric balloon therapy could help those patients at some extent. And again, this is a clinical trial which showed that whatever is the BMI, the intragastric endoscopic balloon could achieve a mean value of weight loss exceeding the threshold we spoke about, which is more than 10% of the baseline. And the endoscopic sleeve gastroplasty also, again, they have a learning curve of 35 cases, so it's not very sophisticated, but again, they achieve a more rapid response compared to the intragastric balloon dilatation, which is exceeding the 10% from baseline, and after 2 years, it ranged between 15 to 20%. So the questions now of our talk: which anti-obesity treatment for the liver transplant candidate? And what is the art of timing? Should we do it before or during or after transplantation in transplant recipients? And who are the candidates for the liver transplantation from those patients? So I will start with the management of obesity before transplantation. What's important here that obesity alone is not a full story. The risk depends on frailty and sarcopenia. And we have to consider the clinical significant portal hypertension and liver decompensation. So before transplantation, these things are very crucial. And from the literature, it's very important to know if we have F4 liver cirrhosis without portal hypertension, still those patients could be candidate for bariatric surgeries. If we have F4 cirrhotics with portal hypertension, drug or pharmaceutical treatment could be an option for those patients. And in decompensated patients, they should go for liver transplantation. And this is one of the abstracts in the ASLD. There is no so much data in this year. We have just only 4 abstracts concerning transplant recipients in case of obesity. And in this abstract, they said there are 4 phenotypes for the obesity and frailty. Frail and obese, and frail and non-obese, non-frail and obese, and non-frail and non-obese. And from this, they found that frailty is the key determinant of prolonged hospital length of stay post-liver transplantation, regardless of obesity status. Non-frail obese patient has the shortest stay. So the problem here that when we have a weight reduction, massive weight reduction for those obese patients before transplantation, and we change those patients into a frail recipients, we have a poor outcome after transplantation. Again, pre-transplant GLP-1 receptor agonist use in post-transplant outcome. They comparing in this retrospective trial 38 patients with GLP-1 receivers and 120 without. And they found that those with GLP-1, they had high rate of pre-transplant PMI compared to the others, and they are more immediate post-transplantation complication in terms of return to operation room due to bleeding, prolonged intubation time, and renal function dysfunction, and graft loss and length of hospital stay. 1 year mortality did not differ. So this is useful. Pre-transplant caution abstract supports that discussing the timing and holding strategies around transplantation, confounding by cardiometabolic severity, and the need for prospective and pre-operative protocol when GLP-1 is used for liver transplant candidates. Intragastric balloon in compensated cirrhotic patients awaiting for transplantation. In PMI more than 35, filled with balloon for 6 months in 8 patients. And they found that there is a weight loss approaching 10% of the total body weight in 6 months, with body fat decrease significantly, no mild change, early retrieval due to symptoms in 2 patients, and decompensation occurred in 1 patient. Malarialized tears occurs in 3 patients, and no portal hypertension related bleeding. Decompensation with or without HCC in 3 patients. So the recommendation here is the intragastric balloon achieve transplant relevant weight loss in selected compensated patients, but it is not a low risk intervention in cirrhotics, and it is typically requiring tight selection criteria, close follow-up and monitoring. Prior to transplantation, bariatric surgery could be performed, and this is a retrospective trial where they have those patients who had done bariatric surgery, and they compared with those who didn't done bariatric surgery in 156 matched control group. They found that the delisting and the deaths on waiting lists is more with the bariatric surgery group than 33% compared to 10% of the control, and the transplant rates is lower in the bariatric surgery group compared to the matched group due to the lot of dropouts before transplantation. So the bariatric surgery group has a hazard ratio of death on waiting list reaching up to 5.7, and this is due to low skeletal muscle area, one of the significant subgroup analysis. So it's bariatric surgery before transplantation is not a bad thing, but we have to select those patients, because the type of surgery could be a role, because those patients who has historically Roux-en-Y gastric bypass, they are not recommended or not ideal in case of transplantation. Nutritional deficiencies, sarcopenia, and malnutrition, again, play part of this game. Bariatric surgery before transplantation, as we mentioned, we have to highlight whether we have portal hypertension, yes or no, and the type of surgery is very important in those patients. Obesity with liver transplantation, when we do bariatric surgery with the operation of transplantation itself. Of course, there are some concerns like the immune suppression intolerance, like rejection due to the repeated vomiting or something. Roux-en-Y is not the ideal for transplant setting to have an access to the biliary system, and the early post-operative side effects is a matter of concern in a frail patient. So simultaneous liver transplantation with a sleeve gastrectomy is very important, and some trials highlight the use of PSOFT score or the oral anti-obesity oral medications could be safe. And in this trials, they showed that in 72 patients who had simultaneous transplantation with sleeve gastrectomy versus liver transplantation alone, that there is a mortality and graft loss was not significant between the groups, but the BMI were significant more with the sleeve gastrectomy group. The diabetes was lower among the simultaneous transplantation with bariatric surgery compared to the other group, but the hypertension was not the same. Lower incidence of graft steatosis, which was again statistical significant, and very limited post-sleeve side effects. In this trial, again, they showed in 11 morbid obese liver transplant who had simultaneous transplantation with morbid obesity, that they have a very poor outcome regarding the survival at 30 and 90 days. But they again said that the BSOFT score, if it's exceeding 15, could be incriminated in this poor outcome. So again, if we select or reduce the other complexity of risk factor in those transplant patients according to the PSOFT score, we might have a better outcome in the combination. And this is the PSOFT score for the simultaneous liver transplantation with bariatric surgeries. And the management of obesity for de novo and recurrent disease, of course, again, the 50% they have during the first year metabolic syndrome, increased mortality with twofolds, good liver status, which is different between the other two different timing, and away from the early phase of rejection. So the sequential liver transplantation for bariatric surgery could be done whenever it is indicating. It started from the 6 to 12 months with the high mortality rate with hazard ratio reached to 7.6. Of course, this is one of the ASLD abstracts which show the GLP-1 agonist utilization post-transplantation, and they found that the exposure within the 90 days post-transplantation with the semaglutide, different types of medication, they have lower mortality and regarding 90 days and 1 year, low graft rejection rate and low readmission. There's no significant difference for the acute myocardial infarction. So again, it could be an option for those patients who are refusing surgery. But in this French trial, they found in 20 patients compared to historical liver transplant recipients that the operation is very, very costly when it's done sequential, and due to the complexity of surgery after transplantation, due to the adhenolysis and hospitalization time, the outcome was carrying out a hazard ratio of 7.6 in those patient post-transplantation. So my take-home message is liver transplant recipients should be screened for long-term side effects of immunosuppression. All status contraindicated with cyclosporin and should be taken in a time gap between them. Bariatric surgeries is better to be sleeve gastrectomy and not Roux-en-Y to have an access to the biliary system. Before liver transplantation, portal hypertension, frailty, and sarcopenia is very crucial for those patients. Bariatric surgery during liver transplantation should rely on the BSOFT score. It's very, very helpful to nominate the best outcome for your patient. Again, the liver is the engine of the metabolism. When you want to do some weight reduction to preserve the muscle power, when you are doing this with a good liver status, you will achieve very good outcome. The oral medication showed very good, promising weight loss without drug interaction with immunosuppression therapy. Still, it's not recommended in decompensated cirrhosis, and the bariatric surgery prior transplantation increased risk of mortality for hazard ratio 5.7 and after transplantation with hazard ratio of 7.6. And surgical sequence in simultaneous liver transplantation with sleeve gastrectomy, they do it after reperfusion, declamping and perfusion, and before the ductal anastomosis, and this is the optimum time for them. And thank you.